My name is Ryan Flannigan. I just recently graduated from the University of Calgary here, their medical program, and I'm going to be going to British Columbia to train for a further 5 years in urology and prostate cancers within that training. So I'll become more familiar with a lot of the content that we're going to talk about today. But I just first want to thank everybody for the opportunity to attend the conference in New York. I attended the inaugural International Prostate Cancer Symposium, and Cornell hosted the conference this year. I believe Dr. Tiwari, who's a leading world expert in prostate cancer, he kind of headed the conference, and they did quite an amazing job with it. So the conference took place over 3 days in May, and they had a significant number of other prostate cancer specialists within the field of urology attend from across the United States, and they even had several big names from Europe attend, as well as other people from Canada. There was a couple urologists from Toronto, Montreal, off the top of my head that I can think of, but it was really well put together, and I think it's going to be an event that's going to be continuing to grow in the future and involving a lot more surgeons. The conference has its role for a variety of levels of training. For example, myself transitioning from medical school to surgical residency, I think it was very useful and informative just to see, where are the leading individuals in the field of prostate cancer with their research, what do they have to say, and it is really interesting to kind of get some insight as to where they think prostate cancer is going to be, in the next 5-10 years, what some of the big changes are going to be with respect to treatment, screening, all those kinds of things that are clinically relevant to the disease. It's also, a really good conference for people that are early into their practice or even experts within their practice in urology. To give you some good examples, if you're starting out in urology and you're working a lot with prostate cancer, you have the collective information and opportunity to discuss some of the questions in management or screening of prostate cancer with some of the world's leading researchers and practicing surgeons. If you're already at the top of the group and you're doing a lot of research, you're treating a lot of people with prostate cancer, then it's a nice opportunity that you can bounce your own ideas off of some of the other leading surgeons that just do things slightly differently. Because at the end of the day, there's a lot of research and there's a lot of evidence to say we should be doing things in a particular way, but at the same time, everybody has their own technique and their own way of approaching things that works better for them. So it was really interesting to kind of see some of these surgeons that write very prestigious papers and are sought after as some of the top surgeons in the world, asking questions to other top surgeons and saying, I have this patient with X, Y, and Z that's just a little bit different than the regular scenario that you might see. What would you do in this situation, or have you encountered this before? So it was pretty interesting that way. So some of the more interesting things that I learned at the conference, there's definitely a few things that come to mind. Personally, I have an interest in kind of the technicalities within surgery and surgical technique. I have a bit of history in competing in sports, and I kind of enjoy that sense of things. And Dr. Tiwari presented a lot of his own data about some of the surgical technique changes that he did in his own practice. So to give you a bit of a background idea, Dr. Tiwari works for Cornell University, is how I understand it, and he's seen and conducted surgery on over 3,000 patients with the Da Vinci robot, and that's a lot of surgeries. So, you know, him being a world expert requires him to have that large of a volume. You know, places like Calgary, which I think we're over 1 million people now, and the area that we serve is probably closer to 2 million. I don't have an exact number, but even with a draw of 2 million people, the whole group of urologists within a year sees about 300 to 400 prostatectomies per year. So still a really high volume, and the surgeons here are doing high enough volume to be very proficient at it and very good at it. With Dr. Tiwari's case, because he has such a high volume of patients that he works with, he can do studies within his own patients, and which is kind of interesting. So what he's done is he's looked at particular aspects of patient outcomes within a surgery. For example, if there's a positive margin, meaning that after they take the prostate out, is there a certain area of the prostate that actually had cancer cells on the margin between the healthy tissue that stays in the body and the cancerous tissue on the actual prostate? So what he found was that in the technique that he was using, most of his positive margins, although they're pretty low, happen to be at what we call the apex of the prostate, which is just one of the anatomical regions that kind of connects near the urethra on the bottom side, inferiorly on the body. And so what he did is he thought, okay, you know, if we're having a lot more positive margins in this particular area, then, you know, maybe we can change technique a little bit here and improve upon that. So put his thinking cap on, or whatever he does to get these great ideas, and he changed his technique and did a study of before to after, and found that he decreased his positive margin rate significantly. So it was just kind of interesting to see, you know, small changes within one's own practice when you look at your own data can be very advantageous for patient outcome. And just to give you a sense of this, a lot of the surgeons here in Calgary are also looking at their own data, not maybe for the same exact areas that Dr. Tiwari is looking at, but looking at their own patient outcomes and trying to find ways to improve upon it. And I just presented some data this weekend working with some of the urologists in Calgary, and they made some very positive strides in a good direction as well for improving patient outcome after looking at their own data from the patients that they're operating on. So it's you know, it's good to see that it's being done locally, and it's also interesting to see, you know, some of these people that just do large amounts of surgical cases. So that was a long-winded answer to one interesting thing that I found, but another area that I thought was really interesting was in prostate cancer imaging. So you can look in the guidelines, and in Canada, and they'll say, you know, with the patient with diagnosed with prostate cancer, you should do X type of imaging, and so on, based on a number of parameters. But I think more of a new evolving field is MRI in prostate cancer. It's not, I don't think it's ready to be adapted as a full-fledged standard of practice in Canada, because there's still a lot of room that they're kind of working with. It's still, I think, more in the research stages, and more information needs to be gathered from it. But perhaps in the future, they can use MRI to actually identify areas that are suggestive of prostate cancer, within the prostate, and then from there it might just give the surgeons a slightly better idea as to cancer location within the prostate to consider for the surgeries. And it just kind of opens up a whole new field as to what they can do with this additional information. But a lot of times, in medicine, it's always an evolving, dynamic field, and we're always striving to acquire new information and more information, because with more information, hopefully you can make a more informed decision or tailor things more personally to each individual patient to hopefully achieve a better outcome. Sometimes, though, you want to make sure that this new information that you're acquiring is understood enough to the point that it is helping to make a more informed decision rather than just having all this information and thinking that, this is going to help us, but in fact, we just aren't quite there with understanding it yet. So just to kind of summarize that, MRI is kind of coming into its own in the US with research, and I think that in future years to come, it might be something of benefit to patients. So thinking about some of the sessions that I attended, there were quite a few. I'd say the most common type of session was probably discussion-based. So somebody would have a lecture, and then there would be a lot of time for discussion. So some of these topics, some of the big hitters would have been screening. So screening has been quite controversial in Canada, the US, across the world. So PSA, prostate-specific antigen, which most clinicians, most urologists use, it's very sensitive to detecting prostate cancer. The tricky thing with PSA is that because it's so sensitive, meaning it will detect if there is cancer, but it will also detect if there are other things. So other causes can also make your PSA rise. So it's been tricky in determining, particular parameters with PSA, how to monitor patients either, before a therapy or once they've had a therapy. So to name a few different things, the PSA number itself, we have age-specific cutoffs, and so that's one way we can look at it. PSA doubling time, so how many years or months does it take for the PSA number to double in size? That's another thing that people have used. PSA velocity, how fast is it going up? So we have cutoffs for all these numbers, and they all kind of input information for us to make decisions in terms of, what type of treatment is going to be benefited the most. But there's a lot of controversy over which paradigms you use and how you use this information. And also there's other things that are kind of coming into the scene, other types of biochemical markers. There's a lot of discussion as to what role those are going to play. So, at the present, there's not a perfect marker that says, if this is positive, yes, there's a clinically significant cancer or disease. If this is negative, then no, there isn't. That would make everybody's life a lot easier and a lot more clear cut. But just the fact that prostate cancer, by and large, is a slower progressing cancer than some of the other ones that we commonly see in our society, such as breast cancer, it makes it a little more difficult to decide what the best mode of treatment might be. For some, it's going to be active surveillance and monitoring things and waiting. And for other people, it's going to be a prostatectomy, taking the prostate out, For others, it's going to be the addition of hormone therapy or androgen deprivation therapy. So screening is kind of at the forefront of all this, and it impacts not only, when a cancer is or is not picked up, but also it also kind of bears weight on decisions to what kind of treatment modality would be best. So there's a lot of discussion about that, and at the end of the day, there's still no clear-cut answer, but there's definitely a lot of work in a lot of people's minds putting in the effort to improve the measures we have, whether it's making algorithms for it, or in terms of creating entirely different biochemical markers, or even with the MRI imaging. Is that going to play a role in terms of screening and determining if there is cancer present, and if there is cancer present, is it clinically significant enough that it's going to need some form of active treatment? So that was a pretty major theme of the conference, I would say. Definitely very complex and not easily sorted through to find the best answers. Some of the other main topics that I'd say were addressed was different modalities of treatment, some of the evidence for or against particular modalities, and at the end of the day, a lot of the modalities of treatment in prostate cancer are pretty comparable, and it's difficult because a lot of the studies out there are designed in such a way that it's not clear-cut even after the results have come in, because there's a bias one way or the other, or just the structure of the study itself wasn't conducted perfectly. And oftentimes it's not at the fault of the person doing the research. It's because when you're working with people, you can't just say, person A, you're going to get a treatment, person B, you're not going to get a treatment. And in a perfect world, from the research perspective, that's what we would do, and then we would have more clear-cut answers. But for person A that you say you can't have a treatment, it's not ethically correct or would be well accepted. So in some circumstances you can do that, in other circumstances you can't. And with prostate cancer, you have some studies that shed a little more light, and other studies that also contribute information, and you try to take the information from all these studies and put it together to have a good functional idea as to how to go about treating each specific person, but it's quite difficult at the end of the day. To give you an example as to where some of the challenges come in, is that everybody has a different medical profile. So for some people that are, take one pill a day for hypertension or high blood pressure, a surgical therapy might be safer for them than a person that has, a list of 25 medications that might, a surgical therapy might be a little more risky for them. So there's just a lot of patient factors that you have to recognize and take into consideration when you're making these decisions. And in making those decisions, you try to draw from the information from each of these different studies. Talking about incontinence, particularly after a prostatectomy and taking your prostate out, there's been a lot of evidence kind of discussed, and offhand I can't give you a percentage number as to how many are entirely continent, after the procedure. I think it's a fairly good number though. And even within those studies, sometimes, people have to be very careful as to what they define to be perfectly continent. So does that mean, being entirely dry and not a drop come out, or does that mean from 10 pads a day down to 1 pad a day? It really just kind of depends on expectations. And I think one of the important points that a lot of the surgeons were trying to emphasize was that, coming out of these surgeries, it's important to have the expectation that things are likely going to improve. But, being entirely perfectly dry, not a drop, it might be possible. But I guess it's important to be informed that, that might not necessarily be the case. Having 1 pad a day might be kind of the optimal, future forecast that you'd be looking for. But there are definitely some different treatment options. I'd say the two probably leading and competing treatment modalities are male slings and artificial sphincters. So slings have been used in females for quite a while. And I think sling use in males is definitely be investigated, but there's not quite as much evidence for it at this point in time. So there's studies currently being done, and with time, the information will come out to say how they compare to the artificial sphincters. The one important thing to consider is that the mechanism of incontinence between women and men is slightly different, especially for men following a prostatectomy. So the slings designed for men and the slings designed for women are slightly different, and they function differently. So I think there's been a few different versions from different companies for male slings, and I think with time they're improving. The artificial sphincters, on the other hand, I think there's a little more evidence for them. I think they're, by and large, pretty successful. But at the end of the day, you have to remember that, doing these surgeries are invasive and definitely have a role for them. But you kind of want to use more conservative options first, and if they work, then perfect. And if they're not working, and then talking with your urologist, seeing if first if they perform the procedures. If not, there's other colleagues that they have that do perform the procedures, and they'd be able to give you more information. But I'd definitely say, from a research standpoint that they discuss at the conference, it was kind of comparison between these artificial sphincters versus slings that actually kind of support the urethra and then help basically prevent urine from coming out. Following prostatectomies, sexual function is something on everybody's mind, and especially, I guess, irregardless if you have unilateral nerve sparing or bilateral nerve sparing, it's still something that I think most people experience some change to, particularly initially after the procedure, and then things for the most part improve thereafter. So my understanding is, and the sense I got from the conference was that they call it penile rehabilitation is an important factor, and if regaining sexual function is something important, then looking at some of the modalities to encourage early use and is important. So there's a variety of different modalities for that. Some of you might be familiar with them. But there's pharmacological agents. These things include Viagra, Cialis, Levitra, and they're all within one class of medications. And I'd say, for the most part, these are probably the least invasive. They all vary a little bit, and some pills just work better for particular individuals than others. One person might say, Viagra always works excellent for me and it does the job. Somebody else might say, Viagra wasn't working very well, but Cialis is, working fantastic. So that's kind of the sense I get, that, they're all in the same class, but they work slightly differently, and some people just respond better to one particular drug than the other. So that's one type of rehabilitation or aid. Other types include vacuum devices. I spoke with one of the reps for their company, and there's a lot of information about different vacuum devices, and I think they've probably come a long way in terms of being user-friendly, and it looks pretty ergonomic in terms of ease of use, that sort of thing. And then there's your injections, and I think their success rate's quite high. For some people, it's just being okay with a small injection to the base of the penis. So those are kind of the three frontline options, I would say. And then after that, then there's your more invasive options, such as implantable devices, whether it's a pump-up design or a malleable design. Those are different options. But I think the important part is that there is some evidence that the penile rehabilitation, or using methods to try to regain the sexual function is healthy, and is a good thing to encourage return of function following the procedures. So thinking about any other quite interesting experiences from the conference, another one that comes to my mind, they had these other sessions that a couple of the prominent surgeons, Dr. Tiwari was the one that I got to participate in, but they took us to one of the lecture theaters at Cornell University, and they had this video feed from the OR where Dr. Tiwari performed a surgery on a patient in real time, and we had the video feed from the surgery camera, and he was doing a robotic prostatectomy. But we had the video feed from the camera, and we had the video feed from the OR room, so we could see him physically operating. And then we had communication between the OR as well as the lecture theater where we were. So it was really interesting. For the most part, he could concentrate on both, and if we had a question, we could ask him a question, why is he doing, the particular technique he's doing that might be unfamiliar to other surgeons that do these robotic prostatectomies. So that was really interesting. And then obviously, in cases where he had to concentrate, and it was a little more of, a technically challenging step, then we wouldn't be talking his ear off. But it was really interesting. It was really neat to kind of watch him follow along as he's kind of talking us through it. And afterwards, he came and debriefed. And it was also really interesting. During that session, you had a number of really prominent surgeons. There's some surgeons from UCLA. There was others from the East Coast that were quite big names, and you see them in a lot of research. And they would stand up and say, I have this patient that, X is different than I've seen in any other patient. I'm not exactly sure what I should be doing in this case. Does anybody else have any ideas? And it just turned out to be this huge kind of collaborative debate and discussion, and everybody would just kind of speak up as to what experience they've had. Say, you know, I've had 2 patients like this, and I proceeded by doing this particular technique, or I've offered them this therapy. And I think that's, you know, a theme that I could probably sum up as being one of the most unique things that I've seen at some of the conferences I've been to, is there's just so much opportunity for people to communicate back and forth and bounce ideas off each other. So it was really like a unique learning experience for everybody that's already at that stage of their training, and they are experts, but they're still seeking to learn more. And, you know, in somebody like my position where I'm earlier in the stage of my training, but it's still interesting to kind of soak up some of these ideas and ways that people go about problem solving with respect to therapy within prostate cancer, screening, symptom management, those kinds of things. So I thought that was probably one of the most valuable things coming out of the conference experience. Because, you know, you can always read research, you can always read papers, but hearing people's interpretation of the papers and, you know, some of their perceived thoughts on shortcomings of present day research or technology, or their ideas as to where technology and research is going or should go, and bouncing these ideas for problems that they've encountered. That was kind of the really interesting aspect to this conference that I think was pretty unique and valuable to no end. The best restaurant, hands down, was I believe Johnny's Pizza. If you're ever going to New York, it's just off of Broadway, and it's this pizza place that I believe is in a old church, and it's quite a big room, and it's a couple stories high inside, and it looks like they just kind of had the bare bones infrastructure from previously, and they turned it into this pizza place. But the pizza is fantastic. It's your typical New York thin crust, and it is just so delicious. We had pepperoni and margarita pizza, and I like my pizza. I eat a lot of pizza. But yeah, by far this beats any other pizza I've ever had. So definitely check out Johnny's Pizza if you ever go to New York. So when I went to New York, one of my friends that I did my undergraduate training with has been living in New York for the past 2 or 3 years, I think. And so he had done this tour, I think 7 times before that. You know, when friends come and visit him, he tours them all around and shows us all the interesting and important New York experiences. So it was fantastic. I think we put on a lot of miles, and I think I made it to 7 different pizza shops by the end of the 3 or 4 days. But we saw Central Park on a couple of different occasions. The conference was actually right across from Central Park, and I didn't realize how big it was, but it's very large, and it'd take you a long time to walk all of it. But it is beautiful. It's pretty amazing to have such a huge green space in such a huge, you know, big urban city. So that was really interesting. And apparently there's this pond, I think it's called Turtle Pond. And I went there, and my friend was telling me that you can see turtles all year round kind of thing. But unfortunately, I didn't see one. But it was interesting nonetheless. We also saw Empire State Building, the Chrysler Building, the Rockefeller Tower. I went up the Rockefeller Tower, and they kind of have a museum within it, and on the walls it gives you a bit of a historical context to the building as to when it was built and Mr. Rockefeller, what he kind of envisioned for it, and all the things associated. And once you get to the top, it's just a amazing view. If you look on one side of the building, it's really close to Central Park, so you just see this huge green square rectangle in the middle of all this urban area. And then you look out the other side, and you see Empire State Building, you see the Chrysler Building, and then in the distance you see kind of downtown the Wall Street and business area. So that was really interesting as well. There's also a number of parks, actually. Bryant Park was pretty interesting. And apparently in Bryant Park, they used to have benches and chairs that were stationary and you couldn't move them. And apparently there's a lot of issues with violence and drugs and whatnot in the area. So somebody came up with the idea of having movable furniture there. So they have these kind of neat little small square picnic table type concepts, and small chairs, and you can move them however you want. And apparently the crime rates decreased by a lot in that area. And so there's a lot of psychology studies, I understand, that took place, or maybe a few big ones, but they kind of recognize that because people could control their environment, then they could avoid some of these conflicts, and they ended up having, you know, less conflicts, less violence, less aggression and stuff. So that was kind of interesting. And then there's this other park we went to. I'm trying to think of the name of it now. I think it's called Highline Park, and they had this old kind of railway track, and it was on a bridge, and they would kind of go out through the city. And I'm not sure when they stopped using it, but eventually they ended up turning a large section of it that probably spanned 20-25 blocks into this park. So they planted trees and grass and a walking path on this old abandoned railway bridge kind of up top, so you have to climb a couple stories to get up to it. And you can just have this really nice walk through the city. It's on the west side of downtown Manhattan, I guess. And you have really nice views of the city. And there's this one part where they had this amphitheater, and so you're a couple stories up from the regular ground, and you're walking along, and then they kind of have this small amphitheater that you drop down, and then there's these glass windows over top of this intersection, so you can people watch in this intersection and just kind of hang out. And there's this seating area, and then I guess when you had enough people watching, you can continue your walk down this park. And yeah, it was really unique and pretty nice place to go. That was one pretty common concept that I thought is because, you know, it's such a big area, and they do have limited space with the big population. They really try to utilize things and utilize their space as much as they can. Another cool area was Times Square. That was my first time being there as well, and it was pretty neat. I went and saw a Broadway film. I think it was called Rock of Ages, and it was really good. It was I hadn't been to a Broadway show before, and yeah, it was fantastic. The music was good, the acting was great, and then when I got home back to Canada, I heard this advertisement that they're gonna have, you know, this Rock of Ages, and it's gonna be all these big name celebrities from the TV and movies. So I'm kind of wondering if it was just like a pilot one that they were doing that we saw, and they're gonna have this other version with all these huge names, you know, maybe within the next year or something. So yeah, I thought that was really, really cool. I also hear that The Lion King is supposed to be very good if anybody's going to New York, going to see a Broadway show. But yeah, I think that probably includes most of the sightseeing I did. We tried to do as much as we could after the conference, but it was good. Well, this kind of wraps up my experience of the conference in New York. Once again, I just want to thank everybody for the opportunity to go to New York. It was a great experience, you know, in seeing the city itself and some of the tourist things. But the conference was, you know, an invaluable experience. I think it's definitely going to be something that I'm going to try to stick into my agenda in years to come, and I anticipate it becoming an even larger conference than what I experienced with years to come. And it's really interesting seeing some of these really big names at the forefront of all this research, and you know, their opinions of clinical care that we're kind of listening to and trying to incorporate in our clinical practices. It's really interesting seeing them all bouncing ideas off each other and talking about the new directions in urology and prostate cancer. So thank you again. I hope everybody got something out of it, and if you ever go back to New York, I think it's called Johnny's Pizza, just off of Broadway. It was fantastic. Yeah. Best of luck with everything. Thank you very much.